In our next component of table placement, we're going to be reviewing the headpiece angle application according to the effect of the AHRY misalignment component. In consideration that the posterior atlas mass is typically much taller than the anterior mass, if you were to observe compressing a vertical weight dropping down onto this, the larger posterior mass would tend to want to squirt posterior out from underneath it. Thus, since we have a right and a left mass, if you were only to apply that vertical compression to one side more than the other, it would typically make the atlas want to move posterior on the side of vertical compression. Thus, when applying the headpiece angle to the rotational subluxation misalignment, if you have a posteriorly misaligned atlas on the side of the ACD, we're going to slightly increase the headpiece angle to create an opening effect of the occiput C1 joint on the side being adjusted, which we will refer to as the proximal occiput C1, C2 joint. This will allow for the larger posterior mass to want to come through with the atlas correction of the sonic impulse. If we have an anteriorly misaligned atlas on the side of the ACD, we're going to slightly flatten or close the headpiece angle to close the proximal occiput C1 joint to encourage the anterior atlas to want to reduce with the adjusting force. Thus, the visual that we'll give you here is with an anterior atlas, we're going to slightly flatten the headpiece to create a slight closing effect on this joint right here, the proximal occiput C1 joint. So here's the influence once again. We'll flatten the headpiece and get a slight closing effect on that occiput C1 joint. If we have a posterior atlas, the larger posterior mass needs to come through a more open joint, so we would slightly increase the headpiece angle to create a slight opening effect on the occiput C1 joint on the side being adjusted. Going on to our fifth step of table placement, we're going to consider a superior-inferior placement of the shoulders to affect the cervical spine misalignment's reduction. If the pattern is a contralateral pattern, we're going to take the distal shoulder and draw it inferiorly in direct ratio to the upper angle, lower angle. So if we have a 1.5 upper angle and a 1.5 lower angle, then we're going to have a 1-to-1 ratio and thus only have a mild influence of distal shoulder draw inferiorly. If it was a 1-to-2 ratio, where the upper angle is 1.5 and the cervical spine is 3, that's going to give us a more moderate influence of the shoulder draw, and the distal shoulder would be drawn more moderately inferior. Too much distal shoulder draw can jam or lock the joints and inhibit the upper cervical complex from releasing with the adjustment. So one little pointer I'll give you is when you're drawing the distal shoulder inferior, if you draw it enough that the skull begins to traction off the headpiece, that's too much shoulder influence. Subtle influence is what we're going after. If we're observing an ipsilateral protocol for care, then the distal shoulder would be drawn superiorly in a proportionate amount to the ACD cervical spine ratio. And if the ACD to cervical spine ratio is a 1-to-1, we would only have a mild influence of raising the distal shoulder superiorly, whereas with a 1-to-2 ratio, we would have a more drastic raising of the shoulder superiorly, and a moderate influence for a 1-to-2 upper angle to lower angle consideration. Remembering that too much influence can also jam the joints, if you raise the distal shoulder superiorly enough that the head begins to fall over the headpiece further, then that's too much influence. And one more secret or hint about how to influence these shoulders is keep in mind whatever influence you do to the distal shoulder, you need to do the exact opposite influence to the proximal shoulder. So if the distal shoulder is drawn superiorly, the proximal shoulder should be drawn inferiorly, creating a rotational influence right at the cervical spine. Our next step is anterior to posterior shoulder placement for the spinous misalignment influence. When the spinous rotates towards the side of the ACD, That would mean that the C2 spinous rotated towards the upside of the patient's side-lying position. The distal shoulder would be positioned anterior to the proximal shoulder. So in this example, you can see that her distal shoulder is positioned anterior compared to the proximal shoulder, which is positioned posterior. And once again, whatever influence you do to the distal shoulder, you do the exact opposite to the proximal. If the C2 spinous was misaligned away from the ACD, so for example in this patient, it would have misaligned to her left with her right side facing up. If her spinous misaligned towards the table, then her distal shoulder would be drawn posteriorly and her proximal shoulder would be drawn anteriorly, creating a rotational influence that will encourage the rotational misalignment of C2 to want to release as the adjusting force hits into the complex. Remember, this is a rotational movement of both shoulders around the spine. And the last step of table placement is to recheck the mastoid to make sure it's still 3/8 of an inch up onto the headpiece, and that the headpiece angle is steep enough to keep the curvature of the mastoid secure. Thus we have now finished the influences of table placement. Our next section is about vector calibration. First we'll begin with the Z-vector alignment. While the patient is lying on their side, their head is rarely level to the ground. When you consider that we got the height coordinate for our atlas correction from a patient seated vertical in the chair, when that patient lies on their side, they're not necessarily perfectly level with the horizon of the earth. Therefore, it is important to measure the head height angle of the patient to determine what Z application should be applied into the instrument to match the patient's side-lying body posture. If this is not done, then the patient will be adjusted with the wrong height setting. The head height angle we measured from C7 to EOP. Many people think it's the neutral spine line, but this will only be consistent with the neutral spine line if there's a 0 mm atlas frontal plane line, and therefore our headpiece height was set where the EOP was in line with C7 and T7. Otherwise, the height of the patient would have been modified based upon the AFP, and our application of height vector coordinate to the patient is aligning it to their cervical spine, which is exclusively from C7 to EOP. So you'll take a digital inclinometer and set it on the C7 spinous process and run it up through the EOP of the patient. So why does this even matter? Well, the instrument will set its 0 setting at 90 degrees to the table, or straight vertical up and down. If the patient's side-lying position had their cervical spine lying parallel to the table, then the instrument's 0 would also set accurately to the patient. The angle of the head, called the head height angle, in this example is 0, and the instrument calibration to this patient would be pure. If the X-ray factor had calculated that the height requirement for correcting this patient was 10 degrees, and the instrument was set at 10 degrees, then the patient would actually receive the 10-degree accurate adjustment from the films. But what if the head height angle was at 6 degrees? If the patient's body position, side-lying, was at 6 degrees, then only a 4-degree instrument setting would be required to give the patient a 10-degree adjustment. So why would we set the instrument at 4 degrees instead of adjusting at 10 degrees? Because the patient's side-lying position provided us 6 degrees of our height. With 10 degrees being calculated on the X-rays, we only needed 4 more degrees of height setting in the instrument setting itself. If we had set the instrument to 10 degrees and not measured the head height angle, we would be adjusting the patient at a 16-degree height, which is 6 degrees errored. In applying the height coordinate, we take the z vector from the X-ray analysis, we subtract the head height angle, and it'll give us the resultant z vectors to set into our instrument. So in these examples, if the z vector from the X-ray measured 15 degrees of height, but the patient was already at 10 degrees, then we would only have to set the instrument to 5 degrees in order to give the 15-degree adjustment to the patient. If the z vector measured from the X-rays was 8 degrees and we had a 4-degree head height angle, that would only require us to have a 4-degree instrument setting. And if we had a height vector from the X-rays of 6 degrees, but our patient's side-lying body position was 8 degrees, then we would actually have to set the z vector of the instrument in an inverted negative 2-degree instrument setting in order to give a plus 6-degree adjustment. You may be asking, if we have to invert the z into a negative setting, doesn't that complicate the application of our rotation? It does. You would have to invert the rotational coordinate in a negative z instrument setting. And we'll go over that in the next couple of slides. Next, we're going to discuss the calibration of the x vector. In our previous example of applying the z vector, we had to measure the patient's side-lying body position from which to apply the height coordinate. Well, in our x vector, we also must measure the patient's body position alignment with the table in order to apply the x vector of rotation. Sighting the patient's alignment with the human eye is usually inaccurate, and it can vary between observers. We don't want to make any assumptions as to where the patient's positioned. Their true structural zero should be precisely measured using the advanced orthogonal x vector zero baseline instrument. So here we have a patient lying down on their side, and when we take the laser template and we locate the TP based upon our X-ray analysis, and we take the crosshair of the template and line it up over the transverse process of the atlas, take the baseline of the template and line it up with the patient's hard palate, level out the bubble on the top of the template, and press the button, it'll shoot a laser off through here, up through and reflecting off of a 45-degree prism, sending it directly down onto the headpiece. This will show us that the patient's true side-lying zero is at posterior 5 degrees in this example. And if we had a posterior 14-degree instrument coordinate, then applying a posterior 14 to the patient's posterior 5 would give us a posterior 19-degree instrument x vector setting. So in this example, you can see that had we not taken this measurement of the patient, we would have been 5 degrees errored in our mathematical application of coordinates. In consideration of how we apply this concept, if our X-ray analysis told us that our x vector was anterior 4, and the patient was positioned in their side-lying posture at an anterior 2, then anterior 4 degrees from an anterior 2 starting point would have us set the instrument's x setting at anterior 6. In our second example, if we had the same anterior 4 application, but the patient laid down in a posterior 8 setting, we would apply a posterior 4 instrument setting in order to apply an anterior 4 adjustment to the patient. And in the final example, if we had a posterior 15 X-ray requirement from the films, and the patient was positioned at posterior 10 as their starting point, then we would position the instrument with an x vector setting of posterior 25 degrees to give us a posterior 15 application. When the resultant z is a negative or inverted instrument setting, the x vector reverses directions. To ensure the x vector is correct, the doctor will need to flip the value of the x vector from the analysis. The math is still exactly the same to solve the resultant x vector. In our inverted z resultant vector examples, if we have a 10-degree calculated height from the X-ray analysis that needs to be applied to the patient for the correction, but the patient's side lying position is 15 degrees. Then we would set the instrument at a negative 5 degree setting in order to apply a 10 degree adjustment to a 15 degree elevated head height angle. In this example, if the X-ray calculation showed us that we needed an X instrument setting of anterior 4, and the patient's side lying position was anterior 2, we typically would be applying an anterior 6 into the instrument. But because we have a negative Z application right here, due to the 15 degree head height angle with only a 10 degree Z application of height to the adjustment, instead of the anterior 4 application, we would have a posterior 4 degree application to the same side lying anterior 2 position of the patient. So rather than setting it 4 degrees anterior to the 2 and giving us an anterior 6, we're going to set it 4 degrees posterior to the 2 and give us a resultant X vector setting of the instrument at a posterior 2 position. The posterior 2 is 4 degrees posterior to the patient's anterior 2 position. And once again, we went posterior 4 degrees rather than anterior 4 because we had an inverted Z instrument application. In our second example, the height from the X-ray was 8 degrees, and the patient's side lying position was 9. Therefore, our instrument setting was negative 1, inverted into a negative. If the X-ray vector from the analysis told us we needed a posterior 4 application of adjusting force to the patient, but the patient's side lying position was anterior 8, typically a posterior 4 application to a side lying starting point of anterior 8 would be anterior 4 instrument setting, 4 degrees posterior to the anterior 8. However, due to the negative Z from the head height angle being larger than the Z vector on the X-rays, we had to take a posterior 4 setting and apply it as an anterior 4 setting to the same starting point of reference, anterior 8. Thus, we set the instrument at anterior 12 instead of anterior 4 because we applied the inverted Z into this equation. Thus concludes our calibration discussion.